Glanzmann's thrombectomy is also autosomal recessive. GEP2B3A deficiency, and in this the platelet count is absolutely normal. Problem is one platelet can't bind with the other through the fibrinogen because of the deficiency of the GP2B3A, and that leads to the prolongation of the bleeding time is what need to be remembered. Then comes the von Willebrand's disease. Von Willebrand's disease, is it autosomal dominant, autosomal recessive, sex linked, like hemophilia? What are the possibility? All forms of inheritance are there in the, there is an autosomal recessive form, dominant form, both the forms are there. Typically there is a deficiency of the von Willebrand factor. Okay, doctor. What is the purpose of von Willebrand factor basically? It has two purposes. Purpose number one is, already you have seen, प्लेटलेट जाके सब एंडोथेलियम को बाइंड होने के लिए von Willebrand factor माध्यम, it is a medium through which it will bind, hence it is required for platelets adhesion. Second, your factor 8 is there, no? When it is circulating, everybody will be watching towards it. It requires a bodyguard for stability. Otherwise, it can be trapped by anybody on the street. Von Willebrand factor provides stability to the factor 8. अगर von Willebrand boyfriend नहीं है तो the factor 8 become easily broken. It don't feel like going out. If it goes out, it will be easily broken. Hence factor 8 deficiency होगा. इसके वजह से क्या prolong होगा? ABTD. And because platelets can't bind with the wall, platelet deficiency also will occur. Hence bleeding time is also prolonged. So both bleeding and also clotting time prolongation, where do you see? Von Willebrand's disease, because it is required for the factor 8 stability is what need to be remembered. Favorite question asked in any entrance you go is what is the most common inherited bleeding disorder? The most common inherited bleeding disorder undoubtedly is von Willebrand, not hemophilia, which is found in about 1 to 3% of the population. So quickly speak about von Willebrand factor, doctor. Where is it produced? It is in the endothelial cells and megakaryocytes, both of them. It will enable the platelet adhesion. Autosomal dominant is the inheritance which will make the von Willebrand factor become low, which is not low in case of hemophilia. But hemophilia also will lead to bleeding time prolongation. Von Willebrand is also lead to bleeding time prolongation because von Willebrand factor deficiency may factor 8 will be unstable. Now there are subtypes in von Willebrand disease. Type 1, type 2, type 3. Out of this, the type 1 is most common. The very von Willebrand factor levels, that is production of the von Willebrand factor from the endothelial cells itself is deficient, which is most common type. Von Willebrand disease type 2 में problem क्या है बोले तो production is okay, but basically it is in the form of multimers. The formation of that multimers is defective in case of the type 2 basically. Then type 3 is very severe form. In this absolute zero von Willebrand factor hai, not decreased production, totally zero, that is type 3. Now if you look at the factor 8, as I already told you, it has two parts. One is coagulant part deficient in hemophilia, second is the antigenic part which fundamentally requires von Willebrand factor for the stabilization. Now what are the clinical features of von Willebrand? As already we said, platelet dysfunction, hence there will be mucosal bleeding. And GI bleeding is possible. And any woman presenting with an unexplained menorrhagia, young female, 16, 17, 18-year-old presenting with menorrhagia, significant loss of the menstrual blood, you should always evaluate the possibility of underlying bleeding diathesis, and if you discover a bleeding diathesis, generally it will be von Willebrand's disease is what need to be remembered. And why it will not be hemophilia? Because hemophilia is X-linked. X-linked means boys get affected. Boys will have significant hemarthrosis, etc., etc., then it is hemophilia. Girls have significant menorrhagia, underlying problem is a clotting disorder, means it is von Willebrand disease, is what need to be remembered. Now, even uremia also can lead to development of a dysfunctional platelet disorder, is what need to be remembered. Now, coming to the diagnosis of von Willebrand disease. APTT will be prolonged, diminished amount of von Willebrand factor and factor 8 activity will be there, diminished values. Now comes the crucial part of the review discussion. Ristocetin induced platelet aggregation will be reduced. All the remaining things अगर अंग्रेजी मालूम है तो पढ़ सकते, मगर रिस्टोसिटिन इंड्यूस्ड एग्रीगेशन के बारे में मालूम होने के लिए फर्स्ट ईयर से अंग्रेजी मालूम होना चाहिए. We recently learned English, no, in medicine final year. So first year में physiology days में we were all from Urdu medium, Telugu medium, and we did not study. Ristocetin is mentioned even in physiology books. Okay, what is ristocetin? Ristocetin is an antibiotic which will cause the von Willebrand factor to bind with the GP1B receptor, so that if you take some plasma, add the ristocetin, right? So what will basically happen? The GP1B receptor will bind with von Willebrand factor, and they think that, oh, already we reached a subendothelial surface and something is there, we need to hang to that. Nothing is there, there is no subendothelium. We are doing it in vitro, not in vivo, no. In vivo you have a subendothelium to which von Willebrand factor should make platelet to bind. But if you add ristocetin, it acts like some anchoring agent and makes the von Willebrand factor bind with platelet GP1B. अगर bind हो गए तो next step क्या है? One platelet binds with another platelet to fibrinogen, right? So if you put little ristocetin into serum, it should make platelets to finish the first stage of agglutination, and they need to go into the second stage of aggregation, and typically you will find the clumping of one platelet with the other. Suppose if the patient doesn't have von Willebrand factor, if you put ristocetin, what will happen? Will the aggregation of the platelets occur? It doesn't occur. So that is the way indirectly we demonstrated there is no von Willebrand factor, by showing a reduced ristocetin induced platelet aggregation is what need to be remembered. Okay, doc? Now, tell me, if it is Glanzmann's thrombasthenia, how will be the ristocetin induced platelet aggregation phenomena? It won't be, or it will be? Anything involving von Willebrand factor or receptor 1B should lead to reduced ristocetin aggregation. Anything which is involving 2B3A need not. So between the two, which one it is? I already forgot it. 2B3A is Glanzmann, no. It should not be affected by your ristocetin. One von Willebrand disease and Bernard-Solier should be affected by ristocetin, if I understood the concept correctly. जल्दी जाने के बाद immediately Davidson open करके check करो. If you discover Glanzmann will have ristocetin aggregation defect, even Glanzmann will show high बोले तो we did not understand the concept correctly. Somewhere some other link we lost. Lot of times as teachers we lose link. It is the student who comes up with a reasonable doubt. will come up by saying that, "Arey kya hai sir, somewhere you went wrong." For now, I am confident von Willebrand disease should cause rhistocytine aggregation affected. Naturally, even if von Willebrand disease is there, if the 1B is not there, even that should affect. But what should not affect? GP 2B 3A should not be affected by rhistocytine. If anything else is there, let me know. It's a learning for me. Okay, doc. Now coming to the various forms of Glanchman, the von Willebrand disease. Type 1, type 2A, ये दोनों में hyperactive agglutination. Type 2 में you have a type 2B. In these people there is a hyperactive agglutination. That means in them the problem is not the von Willebrand factor formation, it is the multimer formation which is problematic. The multimers in 2B fail to monomerize, hence they will typically show hyperagglutination. That is a problem. And in these people we never give vasopressin as a treatment because already they have a hyperactive agglutination. Then you have type 2, type 3, in type 3 there is no agglutination, etc., etc. Now doctor, lot of people von Willebrand disease is very mild. Probably if you try to do rhistocytine agglutination in all our 100 classmates in the medical school, 4 or 5 may have it. They may not be showing any other clinical features. But at the time of surgery or when the trauma is there, when there is an excessive bleeding, then we will basically diagnose. But in general, hemophilics have more severe bleeding compared to that of those who have the von Willebrand disease. So what is the treatment, doctor? Which injection you will remember? You will remember desmopressin injection. What it will do? It will go and make endothelial cells to release the von Willebrand factor that is considered with the treatment. And in the case of the type 1, what is the main problem? 3 scenarios may there can be von Willebrand deficiency, doctor. One is student studied but unable to write in the exam paper. Second, he did not study, just came as a walk into the exam hall and paper was blank. Third, he studied so much that he was thinking which point to write first. That is the qualitative problem. So quantitative problem can be decreased production or decreased release. Third is qualitative problem of aggregation. It is in a multimeric form and it is a useless form. So there is a thing. Between monomeric, multimeric, which one is useless, I am unable to remember. Just check that. I am trying to trespass by saying monomeric become multimeric, multimeric become monomeric. I mean, as a teacher, my job is to leave little confusion to you, so that at least jaane ke baad don't believe that multimeric is bad. Multimeric I think is good, it is unable to form monomer or something was there, or it starts as a monomer, it can't become multimer, some dysfunctional problem. But dysfunctional problem is one of the types of the von Willebrand disease, is what you need to remember.